1/5 of people under 18 experience a mental illness each year, which can harm their quality of life, their relationships, their physical health, and their prospects for the future. 90% of these youth live in lower and middle income countries. In high-income countries, only about 1/3 of youth in need access mental health care, and in lower and middle-income countries, only about 1/10 of youth in need access care. Randomized controlled trials, or RCTs, are generally considered the gold standard in clinical psychology and medical research, and I found that only about 5% of youth psychotherapy RCTs have been conducted in lower and middle-income countries. So overcoming this vast inequity between needs on the one hand and research and access on the other is imperative. This is a very difficult gap to overcome, however, for several reasons. First, the scale of need is huge, with hundreds of millions of youth meeting criteria for a mental illness each year. And second, personal and contextual factors influence what sort of mental health care may be most feasible and effective. Usually, we rely on highly trained experts to provide contextualized and appropriate care. However, in many parts of the world, there are few professional providers available. Even in my volunteer and clinical work in urban areas in the US, needs far exceed the services that are available. This problem is only magnified in rural areas and in many parts of lower and middle income countries, and personalized mental health care as we know it simply cannot meet the scale of the need. Bridging this gap between scale and context is what brought me to pursue a PhD in clinical psychology, where I can use skills in data, statistics, clinical care, and community-based collaboration to start to answer a very difficult question. How can we provide psychotherapies that are effective for individual youth within their personal context at a large enough scale to make a widespread difference? To give you some context, prior to my PhD, I met Tom Osborne, at the time a fellow undergraduate and an entrepreneur. And as he and I worked together to build youth psychotherapies that were both scalable and contextually appropriate, a core tenet of our work was deep involvement of and ownership by people living within the context of psychotherapy implementation, which requires a collaborative and community-based approach. So we've worked together with a large team of international collaborators, including my advisor, John Weiss at Harvard, and many full and part-time staff based in Kenya, to build over the last 6 years our nonprofit Shamiri Institute. Shamiri means thrive in Kiswahili. Shamiri integrates community-based research and service, which has helped us to reach over 130,000 youth to date, and it has been central to my work at Harvard. The Shamiri intervention is a youth psychotherapy that is fit to its context, balancing pragmatism and effectiveness. Instead of lasting for 16 or more sessions, it lasts for only 4. Instead of taking place in clinics, it takes place more accessibly in schools. And instead of focusing on psychopathology, it circumvents stigma by focusing on positive concepts, growth mindset, gratitude, and values affirmations, all of which are research-backed interventions theorized to produce an upward spiral of change in beliefs and behaviors. Shamiri is delivered by lay providers, or recent high school graduates who are trained and supervised by individuals with more training in psychology, who are then supervised by a few expert clinicians available for those youth with the greatest needs. To see whether Shamiri is significantly effective, we've tested it in several RCTs. Students were randomly assigned to either the Shamiri intervention condition or to an active control condition, focused not on Shamiri, but instead on study skills. And their outcomes, including depression and anxiety, were measured over time. Let me show you just a few of our findings. In the trial shown on the screen, on the vertical axis, you can see symptom scores. where lower scores are better. And on the horizontal axis, you can see time since starting the trial, running through 7-month follow-up. We found that in both conditions, symptoms decreased, but they decreased more within the Shamiri intervention condition. And similar effects were seen across 3 other RCTs. Importantly, these effects are on aggregate. So the effects of Shamiri and its elements will differ depending on the internal and external context of each person participating. In another trial in 2021, the context had changed. At this time, schools were under a great deal of pressure following a 10-month COVID shutdown to compress 3 years of schoolwork into only 2 years. Students were so stressed that there was an epidemic of fire setting, started by highly stressed students attempting to avoid exams. And in this changed context, we were somewhat surprised to find that the study skills active control condition was actually considerably more effective than it had been previously. We think that this is because the context of highly elevated academic stress made study skills particularly relevant to reducing students' psychological distress. So building on this finding, we've designed and we've tested 3 therapy components, each targeting one of the 3 most common life problems experienced by Kenyan adolescents: social skills, study skills, and financial skills. Preliminary data show this suite of 3 life skills-focused interventions, reducing symptoms of depression and anxiety significantly more than services as usual in schools. And this is somewhat surprising to us, given that none of these life skills interventions directly target symptoms of mental illness. So, as we have multiple intervention options, how should we decide which youths in which contexts will benefit most from which interventions? This is the question that drives my current PhD research, using statistical and machine learning. And in the long term, I'm interested in personalizing community-based interventions to fit individual youth within their contexts at scale. I want to say thank you to my advisors, to my collaborators at Harvard, Shamiri, and elsewhere, to my funders, and thank you to everyone working to support those affected by mental illness around the world.